And my topic is basically on the wireless RFR in terms of simplifying physiology with the use of wireless RFR. And as Elvin correctly said, I think physiology is one part of intervention. I don't think it has always been a debate whether you see a lesion, whether you would like to treat it because you don't know the morphology of the lesion. And there's been, and that's a very gray zone when it comes to that. And as Anil said, I think we need more biochemical markers which tell us what lesions to treat under these circumstances. Having said that, with limitations that we have today, we know that we have to depend upon physiology in certain situations in multiple cell disease and on a different subset on imaging while doing our interventions. And the fact remains that when you do an angiogram, it only detects 5% of the total coronary tree. The rest of it is all in the microcirculation. A lot of it has to do with the smaller vessels also, which are not demonstrated on routine coronary angiography. So the FFR has been, again, this is the earlier slide, because the current evidence, as everyone said, I think we all know that there are various trials which have demonstrated that there have been significantly lower MACE rates with FFR guided PCI as compared to routine angiography only PCI. And it's a mandate that FFR guidance of multiple cell PCI should ideally become a routine practice if possible. But in multiple cell disease, we had issues with giving adenosine to in multiple stages. So the issue, the thing that came up was the IFR, which is a Phillips patented ratio, which is basically found in the defined FAIR study, that it was equivalent to FFR. And by extrapolating that evidence and by certain other trials which have been used to compare RFR and IFR are significantly similar in performance, and the area under the curve remains the same. It also helps us in guiding treatment in infarct-related arteries in ACS patients, whether we should treat certain other vessels or treat only the infarct-related arteries, and this definitely has proven a boon to those patients. What is the benefit of non-hyperemic pressure ratios? One, of course, is that it can reduce the use of hyperemic agents, reducing procedural time, saving cost to a certain extent, not much in our settings. And that may also help to a wider adoption of physiologic lesion assessment, because the use of adenosine is in multiple vessels does push people back into not using it in some circumstances. The IFR basically believes on the fact that there is a wave-free interval, and that is where the lowest PDPA ratio exists. And this is normally averaged over 5 beats of data collection. And the clinical evidence on use of the IFR has been with a defined flare, in which there was a 1:1 randomization to FFR guided revascularization, IFR guided revascularization with 3 groups in that subset, which basically was a trial which is powered for non-inferiority, and which showed that at the end of 2 years, IFR was equivalent to FFR. And it's non-inferior to FFR for MACE at 1 year, definitely. And the 2-year results also show that it is relatively quite a non-significant difference amongst the two. The limitations are that it assumes that the maximum flow and minimal resistance occurs during a fixed part of diastole, and historically requires ECG gating. So the newer modalities have done away with ECG gating, and you can still get an IFR without the ECG gating, specifically in the newer machines. The question that was raised was, should we look only in diastole, because the lowest PDPA ratio may be different and may exist somewhere else in the cycle, especially in some situations, it may exist in the late systole and early diastole. So thereby the concept of the resting full cycle ratio, flow ratio, which is basically an unbiased identification of the lowest PDPA in diastole or systole and independent of the ECG, and sensitive to small pressure changes during pullback. So it calculates the PDPA throughout the ratio and takes the lowest value throughout the ratio, depending on after using certain anti-noise filters. So this is the flow chart as to how it calculates the RFR, and the RFR is derived from the same aortic and distal coronary pressure signals used to calculate the current physiologic indices. There have been certain studies which clinically validate the RFR, and these are the list of all those tests, all those studies on RFR. And of course, the validated RFR study, which is basically a retrospective study of historical data from the Verified 2 and the IRIS RFR study of 651 RFR measurements were made using the genuine IFR waveforms. And they studied the same data using the RFR signals and they tested the diagnostic accuracy of RFR versus IFR. What it did show that was in terms of equivalence testing, the RFR is equivalent to IFR, and there was no significant difference in either of these two. And it's almost significant, similar in about 98% of these patients. There is significantly high accuracy, sensitivity, and specificity. The Rfr distribution across the cardiac cycle was that in the right coronary artery, there was a certain amount of reduction in those heart cycles with Rfr and diastole. And that was seen occasionally in about 6% of patients, the Rfr in the right coronary artery may be in late systole, which may be missed by the IFR. The reevaluated Rfr demonstrated the real-world evidence that Rfr is clinically and diagnostically equivalent to IFR. And in terms of all accuracy, all the points of accuracies, the diagnostic accuracy, sensitivity, specificity, PPV and the NPV is basically has remained the same. If you look at the prognostic performance in terms of deferred lesion failures, all resting indices, including the Rfr and IFR, had similar outcomes in lesions deferred by any of these measures. And in the FFR French sub-study, it showed that, again, Rfr and IFR have the same prognostic value in predicting MACE in 435 patients. The Illumine-1 plus predict analysis shows that Rfr is accurate in about 94%, is 94% accurate versus FFR. When you use a gray zone of 0.86 to 0.93, and all of us know that below this point, you need to treat, above this point, you defer. And in between these two, it's always better to check using a FFR and compare it with the hybrid approach. The Rfr is advantageous in that it does not have a direct connect to the machine. It has got a wireless interface. So basically, you zero the guide wire by turning on the transmitter, and once it shows, once the transmitter function indicator displays a stable green light, when it is successfully zeroed, and the Rfr snapshot kind of captures the lowest PDPA across 5 consecutive beats. Pullback option is definitely there. That's there in the IFR also, and the height of the step denotes the severity of the lesion and contributing to the functional significance of the lesion. And of course, you can use the same wire, the same system, change the mode, and measure the FFR, which is the same as in IFR also. Just a few these things again. The question mark about the anatomy of the lesions and the substrate of the lesions still remains. But this is a gentleman who came with a acute coronary syndrome, and of course had a nearly total occluded circumflex. LED lesion looked significant angiographically. We did not do any imaging in this patient, but we did a Rfr in this patient. The Rfr in the LED was 0.86. This is a pullback of the Rfr in lesion 1, lesion 2. We did an FFR with 140 mics per kilogram per minute for almost 4.5 minutes of adenosine. We achieved maximum hyperemia with significant symptoms. The FFR was 0.82. So it is found prudent to leave this lesion alone. But being an LAD, we would definitely follow this lesion with regular stress tests, and probably call the patient back in about 6 months for a repeat angiogram and image the lesion at that point of time. This was another gentleman with a positive stress test, having undergone an angioplasty about 5 years back for the distal circumflex. The distal circumflex tendon is occluded. The LED did not look majorly significant. The inferior wall in the inferior-basal segment and the inferior wall here is completely infarcted as far as the echo is concerned. It's akinetic and it is thinned out. So the question was, what do we do in these lesions? So we basically did a RFR to the lesion, and to our surprise, the RFR came as 0.73. So that decided that this is the pullback of the wire in the proximal, from the distal to the proximal. Multiple areas of changes in the pressures, and of course the ostial lesion was not very significant, but the proximal, but the mid LAD lesion is significant in terms of the RFR. The RFR was done for the circumflex. We did not infuse adenosine in this patient because this patient was an asthmatic. But the RFR here was 0.88, and again in a gray zone. So we decided that both the lesions would be treated, and we're given the options of treatment to the patient. And this is the last slide that I have. This again, a gentleman who came with a lateral wall MI and lesions in all the vessels. This was basically we did a physiological assessment to the RCA and to the LAD. The RFR scale is 0.93, 0.92. Did the FFRs, the FFR values, and I'm not sure it in this, but the FFR values in both these were 0.9. Decided to treat these lesions medically, and just treat the circumflex and converted a triple vessel disease into a single vessel angioplasty. And this is a 2-year follow-up on this patient to date. So basically, what I would like to impart is that physiology is still the gold standard in treating, in identifying ischemic potentials of lesions. And evolution of resting indices would make the process simpler and faster. But we would be happier if you had some more light on these resting indices and their contribution and their comparison with FFR and certain specific values that we can say that these values are normal, these values need to be investigated, these values can be left alone. And of course, wireless FFR is easier in handling the wire compared to the contact pressure wire, though the Philips has improved its wire in the current systems. And of course, a 0.014 wire with the Rfr pressure wire is a soft tip wire, and it can be used for a simple PCI tool. Thank you very much, and I hope I was well in time. Thank you.
So great, Ajit. You've actually raised a lot of questions, and I hope Elvin is there. I think he's already moved out, but it would have been nice to hear his view, whether he would have liked to take your first case for a combined study and do maybe an OCT at the same index sitting itself. And I have only one question: that do you think that the pan cardiac cycle advantage of RFR over the other resting non-hyperemic indices confers a distinct advantage? Do you think we should test it? Is it applicable only to the right coronary artery, or should we test it in all the coronaries? And well, I still think that one step which probably Abbott has still got to do is to get automatic co-registration so that more precision PCI can be done with their system. And then they have an automatic co-registration for the OCT, and if you can get the same thing done even for the RFR, it will become a more robust system.
I think you're right. That's where they probably fall back on, because Philips already has its automatic co-registration for the IFR system. And though they say that there is a issue with the PDPA as far as the right county is concerned, I think we still require a lot of data to come out on this before we say that's the only reason why we would do an RFR. Otherwise, there's little much to compare between RFR and an IFR as far as I'm concerned. I think like I said,
since first MBBS, we were taught that the left coronary artery fills only in diastole and the right coronary artery fills in systole and diastole. So, and here is a pan cardiac cycle technique which uses non-hyperemic pressure indices. So it's a good question, but I think we need to prove it.
But I mean, I'm going to ask you a question because I had a very funny patient where the RFR was 0.8 and the FFR was 0.92. I mean, I did multiple runs and I still got the same answer.
So here is the role for doing imaging, because you probably understand, because there are limitations of both hyperemic and non-hyperemic indices. It could be there are a lot of variables and there are a lot of assumptions we make. There are a lot of mathematical assumptions at every stage. And so this is one place where we can figure it out, is by adding imaging or by actually using other things like CMR and IMR. I mean, I always say this in every meeting, but if you instill chilled saline and you put a standard PDCA wire and you connect a crocodile clip, if you see ST elevation, it is significant. So you don't need to have fancy gadgets and fancy devices. We've tested this out time and again. It correlates very well with a positive FFR or IFR. So it all depends on what you want to, how much time and energy you want to spend. Getting an insight, getting a passport and a visa is okay, but you still have to enter the country. So once you get that, do imaging, proceed to your work. So that's how most people would plan their workflows. But a great presentation, and it was good to see you.
And same here. Always good to see you. Thank you.